How do you apply some of this genetic data and genetic information in the actual treatment of some of the individuals, particularly when they land on your doorstep and you're trying to navigate some of the treatment options for them?
Yeah, it's a terrific question, Dr. Lutz. And we're a true partnership, I think, whether you're in the community, in academia, and university, and pharma, it's all hands on deck. And I think that kind of approach is really important when you're thinking about genetic and genomic testing. You know, for those in the audience who's not sure what BRCA is, there's still sort of this knowledge gap with everybody. So it's not just the patients or the community or the doctors, it's just a new way of thinking about cancer. Although we know cancer is inherently a genomic problem, you know, there's something wrong with the genes that's driving whatever is the story for that particular cancer. In prostate cancer, we know about a quarter of the men have this breast cancer gene or some family members in there that are not acting right. I think the struggle here still today is that this information is fairly new. The two medicines that Dr. Hafron had alluded to was just approved by the FDA in May of this year. So getting the message out is still something that we need to do. But think about this. You're not even sure if you're a candidate for the pills if you don't know your testing status. And recently at a big international meeting, a very well-known urologist, Dr. Neil Shore, looked at a set of data from what we call the Flatiron data. So it's like thousands, 5,000 men in that database who have prostate cancer. And then the question was, well, how many of these men are getting tested in any type, whether it's an inherited gene and you want to know if this something runs in the family or whether this is just cancer specific. It was an overwhelming number of 13%. So we have these great new drugs and a new approach, but if we don't understand that there's a test that you have to do to accompany that so that you know the status, then we're a little behind. Now, like you said, in breast cancer, that's, you know, less of an issue. People kind of know to ask, but in prostate cancer, we're not trained to ask. So forums like this is really important to spread the knowledge.
Yeah, and Elizabeth, I would just like to add to that too, is that what people don't realize, and Michael, you alluded to this, is, you know, we talk about the BRCA gene associated with breast cancer, but when you look at the numbers, the incidence is actually higher in prostate cancer patients. So we assume it's called the breast cancer gene, it's BRCA, but really when we started, you know, peeling back, you know, the onion a little bit, we see that, you know, prostate cancer patients have a higher incidence of these mutations. And I think your point about integrating and implementing this new technology is critical. And there's a huge education gap out there, you know, patients, physicians, we need to work on that. And just recent approvals that came out, you know, maybe a couple months ago, is now we have the ability to screen all prostate cancer patients for BRCA1 and BRCA2 mutations, which we literally didn't have 2 months ago. CMS or Medicare will pay for those testing. And when you look at breast cancer, every woman who's diagnosed, or most women who are diagnosed with breast cancer, they get BRCA screened. And what we're trying to do, and what we should be doing locally and nationally, is that every prostate cancer patient, I believe, may be somewhat controversial, but I think where we're headed, if we're not doing it now, we'll be doing it in a few years. Every prostate cancer patient should be screened for BRCA1 and BRCA2 gene mutations.